Good evening, everyone, and welcome to Doc Talks. We're so glad everyone could be with us. We have a lot to catch up on, and we'll go ahead and let Dr. Tennant take it from here. It's all yours. Thank you, Doc.
Okay, all right. Well, thank
Thank
you
you.
very much. Welcome to another session. Uh, we've got an interesting guest coming on, and of course, Dr. Ibsen's going to weigh in a little bit. I have two subjects that I want to cover here in the educational part before we interview our guest. First, I should tell you that the interest in the Epstein-Barr virus has really starting to peak. Doctors everywhere are starting to understand it. People are starting to make diagnoses they've never made before. The realization that viruses can be parasitic and then can be activated and cause disease really may be the best medical understanding of this century so far. It really is profound. So pretty much on each of these sessions, I'm going to try to do some fundamental teaching, if you will, on how the viruses work. There are some great misunderstandings, and a lot of the what we now know about them is a little shocking. There's no two ways about it. So let's cover a couple of things about the Epstein-Barr virus that both patients and practitioner and families are going to have to know. Okay, now the basics is that Epstein-Barr virus is a herpes virus. Okay, now it's technically known as herpes 4. Now, everybody is familiar with herpes 1 and 2 usually because those are the things that cause the blisters on the genitalia or on the lips, and they're familiar with herpes zoster. Now, the reason I point this out is that these are parasitic viruses. They live in our body in different places, and then they will periodically reactivate. Now, we think they reactivate during times of stress, and everybody has either experienced themselves or they've seen a close family member or loved one have reactivation of one of the herpes viruses. Everybody, if you're an adult, has seen somebody with shingles, and then shingles is really herpes zoster. Okay, so that's one of the herpes viruses reactivating, and it mimics chickenpox after it reactivates. You don't really need to know that. You just need to know that this is a parasitic virus that lives in the body that reactivates and causes shingles from time to time. The herpes number 1 can cause blisters usually in the mouth or on the lips or on the genitalia, and then the blisters disappear for a while, and then they may come back. So the herpes virus is a virus that is well known to enter the body, usually when we're children, live there, and then during times of stress reactivate. And incidentally, if you happen to be one of these people that has pain and also has episodic shingles or herpes breakouts, you probably also have Epstein-Barr autoimmunity, and you're at very high risk to be in that category. Okay. Now, I just used the term Epstein-Barr autoimmunity. That term probably will end up being part of the medical lexicon, and I need to explain it a little bit because it may well be that everybody watching this program who has intractable pain may have Epstein-Barr autoimmunity, or at least a lot of you do, and you don't know it, and we never knew how to diagnose it till now or even understood what it would do. Okay, now the thing that made it difficult to understand Epstein-Barr virus, it doesn't break out on your skin like the other herpes do. So nobody knew that people were having breakouts, they were having reactivations, but nobody knew it. Now, people would feel bad. They'd have fatigue, they'd have headaches, they'd have dizziness, they'd get sick, and a lot of times not know why. And that was a reactivation of the Epstein-Barr virus. And so we now know that a lot of people who had these rather mysterious symptoms, and incidentally, a lot of times they were called psychologic because we didn't know what caused them, but it was really Epstein-Barr reactivation. Now, the Epstein-Barr virus lives as a parasite in two places in the body, and this is important to know. One is in the throat, because it does cause infectious mononucleosis or throat infections. So it will parasitically live in our membranes behind our nose and throat. Is known as the nasopharyngeal passage or membranes. But the second place that it lives is in the human lymphocyte. Now, this is very important because a lot of viruses don't live there, but the Epstein-Barr virus is a parasite in the lymphocyte. Now, what is the lymphocyte? Lymphocyte's been known for many years as the immune protection white blood cell. But what I want you to know is that lymphocyte is floating around our body. Okay? Now, when it floats around the body, that means it goes to the tip of your big toe, to the top of your head, to your ear, to your intestine. It goes all over the body. All right? Now, that should tell you something right there, and that is when that virus does reactivate, the lymphocyte may carry it anywhere in your body. Okay? Now, we know something about that. When that Epstein-Barr virus activates and that lymphocyte starts carrying it, maybe it carries it to your wrist and gives you carpal tunnel syndrome. Maybe it carries it to your face and you get trigeminal neuralgia. Maybe it acts up in your throat and you get burning throat or burning feet. Maybe it goes to your bowel, and that's why you get irritable bowel. And so we now know that a cause of migratory pain disease, which was described by Dr. Fothergill clear back in the 1700s. There's even some indication Hippocrates may have noticed migratory pain syndromes. But at any rate, because the virus is in the lymphocyte, it can cause a breakout of pain darn near in any tissue in the body. Okay? So that's the first thing we want people to know. All right. It's not just your spine. Okay. Now, the next thing I want people to know is what causes it to break out. Well, we know it's some kind of stress. Now, you have to think of stress differently than we do stress of when, our credit card's overdue, or when our, kids has a failing grade or something like that. The stresses we're talking about here are stresses that would raise your cortisol and your adrenaline levels for several hours to days. Things like an infection, like a meningitis or a pneumonia or a Lyme disease, or it might be a severe accident, either automobile, domestic violence, military, falling off a roof, some severe trauma, and it could be medical trauma also, a surgery, delivery, things like this can do that. The other thing that will cause it to reactivate is psychological stress. Now, we're not talking about normal psychological stress. We're talking about the kind of stress, and most of us know about it, the kind that just gets you to the heart, and you're depressed, you're unhappy, you're hopeless. Things like PTSD, things like bankruptcy, loss of a child or a life, a divorce. Those kind of things can stress the body's hormonal system and allow the Epstein-Barr virus to reactivate. Okay. Now, the reactivation is what is not understood. Doctors don't know about it very much yet, but they're sure learning very fast. Patients and practitioners don't know about this, but you're going to have to know that when this virus reactivates, in some ways it's far more serious than just breaking out on your genitalia or giving you shingles. It's far more serious because two things happen. One is the virus can be carried by the lymphocytes into tissue. And since it's reactivating and duplicating, it breaks out of the lymphocytes and decides to nest in your tissues. Okay? Now, if that virus is nesting in your tissues, what happens is one of two things. It can either start the tissues to degenerate because it's causing inflammation and adhesions and causing the tissue to degenerate and lead to a painful condition, or Interestingly enough, it can make the tissue start to grow and you grow into a cancer. Now, I've always wondered for years why so many of my intractable pain patients got all kind of weird cancers. Well, I got a pretty good idea now why. Okay. Now, so remember, when it reactivates, the virus will settle in tissues and cause tissue to degenerate, or it can proliferate the tissue and give you cancer. Now, it does a second thing, which is a sad commentary, but one you're going to have to deal with. All of us are going to have to deal with. It causes an autoimmune disorder, and some of you have heard me talk about it. I want to try to keep it simple. An autoimmune disorder means that it creates what's called an autoantibody. Now, an autoantibody floats around the system and attacks your tissues and it thinks your tissues is some virus or some foreign object. It mistakes your tissue and starts eating away your tissue like Pac-Man. Okay? So, two things that I want everybody to at least understand. When we say Epstein-Barr reactivation and autoimmunity, we mean that the virus has reactivated. It is now living in your tissues where it shouldn't be. It's escaped the lymphocyte. And then secondly, it's causing autoantibodies that's eating away at your tissue. Okay, now let's talk about what tissues are we talking about. They'd like to, I guess the viruses are like humans. They have their favorite meal. Now, their favorite meal is nice soft tissues, things like fascia. That's giving you something like a myofascial syndrome. It likes to attack membranes, and membranes, for example, around muscles or in your throat or in your intestine. And certainly the arachnoid in the spinal column or spinal canal is a membrane, loves to attack the arachnoid and give you pain in your neck, pain in your lower spine. It also likes to attack small nerves. We now know that it's probably the major cause of small fiber neuropathy and things like pudendal neuropathy and some of the terribly painful conditions that we have to deal with. Now, we can kind of talk later because we have to have a strategy to deal with both of these conditions, both the invasion of your tissues and the autoantibodies. So that's part of treatment. One of the things we didn't know is a lot of the protocols that have been recommended by doctors for years for rheumatoid arthritis or for arachnoiditis or multiple sclerosis really were attacking the virus, either the invasion or the autoantibodies. We didn't know we were doing that. We just know you got better when you took ketorolac or prednisone, and you got better. We didn't know why, but that's part of it. Okay, that's the Epstein-Barr lecture for the day. And again, you're going to have to know about this if you're an intractable pain patient. What I want to talk about now is I think a lot of you know that our foundation has started a study in which we call stopping the deterioration of adhesive arachnoiditis. Now, arachnoiditis has sort of almost emerged as that along with maybe CRPS and some strokes and some other a few conditions, but it's probably the major condition today that gives people a terribly horrible pain. And it also deteriorates. If you don't control adhesive arachnoiditis once it starts, what happens is that you develop probably intractable pain. You start developing paralysis of legs, feet, and maybe arms. You develop neurologic problems with your bladder and your bowel. You can't start thinking because it interferes with spinal fluid flow. You develop paralysis of the legs. You end up maybe in bed, and then you end up with a shortened life. So adhesive arachnoiditis is a terrible, terrible disease. My foundation is certainly putting our best efforts into trying to figure out how to slow down or stop the progression of this disease. Now, first off, I want to thank the people who have joined the study. We had far, far more people want to participate than we ever imagined. And I want to thank all those people who have taken the time to fill out our questionnaires and send them, because we're going to take each one of those and try to maybe give some suggestions to everybody in the study, but we're going to take what we learned collectively to try to help people everywhere. Now, I've taken a look at the first 24 or so uh, uh, questionnaires that have come in. Now, you might be surprised that one of them's from South Africa, I think one from Spain, two from the Netherlands, one from Germany, one from Britain, one from South Africa, and the rest are from the States. But I've taken a look at about 24. And one thing jumps out at me. Out of this 24, about 80 or 90% of the people complain that their pain is just not controlled. Now, to deal with adhesive arachnoiditis or any severe pain problem, yeah, you hear me talk all the time about let's deal with the underlying cause. Yeah, we're not going to stop that. But if you don't get your pain relieved, you can't think, you can't function, you can't analyze, you can't develop a treatment plan, you can't do your exercises, you can't eat right. In other words, pain control is sort of number one as what you've got to do. Now, here's what I've seen in this first 24 cases. And incidentally, this is one of the first times in my career that I've been able to lay out on a conference table 24 treatment plans from all around the world and see what they're doing. And I must tell you, I'm a little depressed. I'm a little depressed because I only personally felt that 2 or 3 of these 24 cases had what I considered an adequate treatment plan, an adequate pain control program. And so I'm going to take tonight and explain why I thought they are poor, exactly what's happened, why aren't we getting better pain control. And so that's what I'm going to talk a little bit about, what we've seen in the study and some things that I personally believe. A lot of people may not agree with me on what I'm about to talk about. But nevertheless, I want to give you my thoughts about what's going on with the very poor pain treatment. Now, let me talk to you about something else. Some of these people who complained about the worst pain have implanted pumps. They've got implanted electrical stimulators. They're taking 1,000 milligrams of morphine equivalent a day and not getting good pain relief. And so I don't want you to think it was just a lack of opioids. A lot of people were getting a lot of opioids, 2 and 3 opioids, no pain control. So why? Well, I'm going to give you my reasons why and my theories as to what is going on. Now, to do this, I'm going to have to give you a little history about pain control that now has gone on in the United States for just about 50 years. Okay? And to understand what's happened and let you know where I'm coming from on it and where I believe, and not that everybody even knows what I'm talking about, but anyway, I'm going to give you my thoughts on what's happened and what we do about it. Now, in 1974, 2 researchers out of Johns Hopkins, by the name of Candace Pert and Norm Snyder, discovered what was called the opioid receptor site. Okay, that was 1974. Now, I was a young researcher involved with about 50 people in the country who were studying opioids for both pain control and addiction. And so I actually got to hear them talk about their prize-winning discovery, the opioid receptor site. Now, that discovery caused, over the next decade or so, a search for other receptors for such neurotransmitters as dopamine and serotonin and GABA. But the discovery of the opioid receptor site set out an understanding of pain that I guess is not understood today. Now, I'm going to explain it to you. First off, I use the term receptor site. Now, why is that? Well, it turns out that a receptor site is a little protein ball, microscopic protein ball, on nerve endings, some nerve endings in your brain and in your spinal cord. Now, up to this time, no one really understood pain. We knew people had pain, but we had no understanding as to how the brain or the spinal cord understands pain and what it does about it. Okay, I'm going to give you the fundamental understanding of pain. Now, to do this, I'm going to draw you a foot. This is a foot. Okay, you got a foot. Everybody, take a look at your foot. Now, let's say you got a severe case of plantar fasciitis, you sprained your ankle, you got diabetic neuropathy, you got some problem with the ankle on down. Now, what happens in this area that's damaged, whether due to a neuropathy like diabetes or arteriosclerosis or plantar fasciitis, you emit electricity, bioelectricity. And that bioelectricity enters your spinal cord. Okay? You gotta go. So, okay, so you got bioelectricity going to the spinal cord. Now, rather than call it bioelectricity for short, researchers and some physicians use the term signals. You send a pain signal to the spinal cord. And the spinal cord takes that signal and takes it up to the brain. Now, in the brain, you've got these little round balls called receptors. Why are they called receptor? They receive the signal. You got it? They receive the pain signal. So that's where the term receptor comes from. All right? You receive this bioelectricity generated by this disease or injury out there on your foot or maybe your ankle or your cauda equina or maybe your ear. Okay? So you've got these receptors, mean it receives something. However, let's go a little step further. There was a second reason they were called receptors. These receptors are made by the good Lord to receive those signals, process them, and discontinue the pain, stop the pain. That's the job of that receptor. Now, how does it do that? Guess what? It receives something called a neurotransmitter. Okay? An ET. And the opioid receptor, what does it receive? Something called endorphins. Now, you ever spell the word endorphin? ENDORPHIN. At those meetings after the opioid site was discovered, some of those bright old researchers decided to call the neurotransmitter that activated the receptor endorphins because it stood for END. That's Latin. Orphine is the last part of the word morphine. You got it? Now, nice simple system. You got an injury out here on your foot or somewhere in your body. You got a bioelectric signal that goes to the spinal cord. The spinal cord, on its electric wires, just transmits it up to the receptors. And that receptor, if it's functioning properly, shuts down the pain, eliminates it, gone. Vamoose. Okay? So that's the way it works. But the receptor's also got to have its natural neurotransmitter called endorphins to activate it. And what we knew very shortly is that if the endorphin wasn't adequate or the receptor wasn't adequate, we could give somebody morphine or codeine or hydrocodone, one of the opioids, give you pain relief. So that's why to this day, with severe pain, we're going to have to use opioid drugs, okay, to trigger that receptor, to receive the receptor. So when we use the word receptors, remember, does two receivings, one from the pain signal coming into the spinal cord and the brain, and secondly, to receive this neurotransmitter. Now, over a period of about a dozen years later, there was a fury of research at that time. The best the country had in this country, plus some other countries. It was a really communal effort. I participated on the clinical levels. I didn't have the brains at that time or the knowledge to do a whole lot of helping, but I got things started, and so I started my own intractable pain clinics in about 1975, about a year later, because we understood for the first time in history how pain was processed. Okay? Now, over the next few years, other receptors were discovered besides the opioid receptor. And we developed a theory of pain that lasted in this country for 25 years. But it's a theory, it's not a theory, it's what we believed. And we believed in a concept, and that was that pain, severe pain, had to be dealt with by a certain number of receptors in the brain. And in a short period of time, between about 1994 and about 1985, there were identified about 7 receptors in the brain that had to receive these signals to relieve intractable pain. And so, up until the turn of the century in the United States, intractable pain, severe chronic pain, was treated as a receptor deficiency disease. Technically, it could be called that. And we did call it that. No, there wasn't a lot of us interested in it in those years. But guess what? We had a whole lot better pain treatment in those years than we do now. Okay? I'm going to bank that one. We did better pain treatment in 1985 than we're going to do in 2025. Okay? It was much better, in my opinion, because we believed, if for all practical purposes, we believed that severe intractable pain was a disease, or if you will, a disorder in which receptors were inadequate or deficient. Okay, now we've got to go to our guest, but there's about 7 receptors in the brain, and 3 of those are called the primary or the majors, and then there are 4 that are minor or lesser. Now, the 3 that are major are endorphin, dopamine, and GABA-aminobutyric acid. The 4 that are secondary are serotonin, cannabinoid, N-methyl D-aspartate, and adrenergic. Now, of those people that I interviewed or looked at their pain records, out of 24, only 1 or 2 were doing anything about their dopamine receptors. They're not going to get pain relief, in my opinion. Okay, so what happened to the theory of receptor disease and treating those receptors for intractable pain? Right around the turn of the century, accompanying the technical generation, the technical inventions of the computer, modern medicine developed a lot of technologies. Okay? And so the concept of treating receptors went out the window. I doubt if any of you even heard this before. And I doubt if your doctor has. Okay? Why? Within about a 3 or 4 year period of time, there were about 4 or 5 technical advances in pain treatment. And you should know what they are, because it was these 4 or 5 developments that threw out the window the concept of treating receptors. Okay? First off, epidural injections. These were all developed. Second one, implanted stimulators. Thirdly, the implanted morphine pump. The cannabinoid development, which did away with benzodiazepines, so this way you could just take baclofen or gabapentin. And the lastly, the opioid formulations of the patch, the fentanyl patch, and the long-acting morphine and oxycodone drugs. Those 5 developments said, we don't need to worry about receptors anymore. Forget all that stuff. We're going to have a specialty called pain management, and the anesthesiologists are going to take that over. And we're not going to need to worry about receptors anymore. These 5 things are going to take care of things. That's where we stand to this day. Now, let me make no mistake about it. These developments around the turn of the century were marvelous. Millions of people have benefited by those developments, no question about it. But there's a lot of people now with severe intractable pain conditions that these are incomplete or don't work very well. And in my opinion, we need to go back to the concept of what I call treating deficient receptors. Time doesn't permit me to go into it except to say this. The receptors need nurturing and they need activation, the two components. And that means you've got to keep that little ball of protein nurtured, energized at all times. And then you're going to, if your pain is bad enough, you're going to have to trigger that dopamine receptor and that GABA receptor, serotonin receptor. And I know I've talked about it before, but you'll hear me talk more about it in the future. But again, this may be kind of deep, and I'll just make no apologies for this. I think I may be the only person left in the medical community in this country who practiced and understood when and how the opioid receptor came about, its meaning, and the development of what we called receptor deficiency disorder, and you had to take care of those receptors to get good pain relief. And I'm going to recommend that a whole lot of people go back to doing this. It's not just higher opioids, but you've got to treat the underlying disease, but you've got to trigger a lot more receptors than just one, which is the endorphin receptor. So you'll hear me talk more about it as time permits in future sessions. With that, Jamie, do you want to bring on our guest?
Yes, sir. Welcome to Doc Talks, Michelle.
Thank you. Thank you for having me.
Thank you, too.
Michelle, tell us about, first off, where do you live? How old are you? What happened to you?
I live in Cape Girardeau, Missouri.
Okay.
I'm 56 years old, or 56 years young. And I was born very premature in 1968, and my inner ears were not developed. And so starting at age 6, my mother and father took me to see Dr. John J. Shea in Memphis, Tennessee. I don't know if you remember Dr. Shea.
Yes, yes, I do.
Okay, I thought you might. And he did subsequently he did 18 reconstructive inner ear surgeries. He made my eardrums out of veins that he took from my wrist, and he made the 3 bones in the ears, the stapes, the malleus, and the inca. I think I've got that correct. Out of cartilage that he took from my hip. And so he is the reason I hear today. I hear with hearing aids, but I hear. So praise Jesus, I hear.
Good. You can hear us okay?
Yes, I can, sir. Thank you.
All right. So did this lead to your pain, or how did your pain come about?
The pain started, I woke up in one of my very first ear surgeries, and they didn't know about ultra rapid metabolizers at that time. But from then on, they would drug me up so badly with anesthesia that I would just be sick as I could be after the surgeries. And after surgery 16, the pain started and never went away. And before, they had gone away, after an appropriate amount of time and, recovery. But after surgery 16, they did not. It did not go away. So I just ended up with pain in my both ears. Deep pain. And my claim to fame is my ears are in textbooks.
You could have a worse part of your anatomy in a book, Anyway,
yeah.
Is your pain now, do you feel it around the ear or down your face, down your neck? Where does your pain radiate, or where
it radiates into my eye socket. It radiates down in my neck. When doctors have asked me what it feels like, the easiest way to explain it is just a very deep earache. that, you know, just like from the deepest part of, I guess, where it could come from, just a very, very deep ache.
Yeah. Well, you're very fortunate they were able to do reconstruction surgery where you can hear now. That's great to hear. Of course, you had the top guy operating on you, so
Absolutely.
yeah. So
Dr. J
that.
saved my hearing.
Yeah. Now, what do you do for your pain now? I mean, you've got it in an unusual location, but what do you do?
Yeah.
Yeah, what do you do now for it?
I take hydromorphone, and it takes care of it.
Now, besides that, what else are you doing for your pain?
I stay very active. I have an 11-year-old daughter that I had when I was 44, after we were told that we would never have children, uh, in vitro or naturally. I'm a clinical psychotherapist. I got my master's and did my research on the use of opioids to treat chronic non-malignant pain.
Okay. Yeah. Well, now, you just heard me give a nice lecture about trying to do other things besides the opioids. You must be, otherwise, you must take some supplements or do
Oh,
something.
yes. I take many, many vitamins and supplements. I really concentrate on my microbiome, my gut microbiome, and keeping that healthy. And just, I really concentrate on what I eat and what's in what I eat. I try to eat very chemical free, very whole foods. Um, so I do quite a few things for the pain besides just the opioids.
Yeah. Well, how about being a little more specific? Because my guess is in some of these supplements, you're doing a few things to keep your receptors working. Okay. So
Okay.
you may not know you're doing that, but but that's what you are doing. So give us a little rundown on your favorite vitamins, herbs, and what have you.
Okay. Well, I take a just a multivitamin by New Chapter, and it covers the perspective, you know, just of a multivitamin. Then I
Hmm.
take a vitamin D3 and K2, which I'm very fond of. Then from Dr. Gundry, I take what's called Total Restore and BioComplete 3. And it is a system that helps keep the flora and the bacteria in your small, you know, your intestines healthy. And then I also take a new product that I just started because I suffer from lovely inability to uh, use the restroom in the second phase of using the restroom. And so I take a product called Elima Pure, and it's all natural and has aloe vera and senna, but it doesn't bloat. It doesn't bloat you or anything like that. And it has let me see what else it has in it: senna leaf, psyllium husk, flaxseed oil, aloe vera gel. Um, and it's just, I found it to be very, very effective.
Okay. You got some more on your list?
I take a can we just be very candid here?
Sure.
Okay, I take a vaginal probiotic to keep that flora healthy. I take a daily digestive uh, prebiotic and probiotic. It's it's all three pre, pre, and the one in the middle and post biotic fibers, and that's all really I'm taking right now. I am constantly looking for new things to help myself, if I think it will benefit my body. And I learned a lot of things doing, my master's research on the use of opiates to treat chronic non-malignant pain. And my mentor in grad school used it at the International Pain Conference in Mexico City in 91. And
Okay.
so I try to do as much as I can to help myself. I try to just not complain and go about life and concentrate on the positive. I do a lot of mental therapy, with myself, about staying out of the dark places and staying in the light. And I have a very, very deep faith, and that helps as well.
You bet. On your diet, is there any special foods you either stay away from or feel helps you?
I believe that eating whole foods without chemicals, benefits me. I think a lot of people are unaware of what is in their foods, especially processed foods. And I cannot eat, I try to stay away from spicy foods, very foods that will activate my acid reflux. So I just try to eat fresh and whole.
Just, Mark, I'm calling you to say some things. A couple of things about your supplements that I really like. It's old fashioned, but multiple mineral and vitamins. One capsule or tablet of practically anything that's on the market each day is well worthwhile because it's got both minerals in it and vitamins. That's the first thing anybody with pain ought to make sure they do. Take some kind of multivitamin mineral product. It's amazing how well it might do. Second thing you're taking, which I wanted to make, we've never commented on this show, but that's aloe vera. Aloe vera has a lot of hormones in it. And aloe vera is, of course, been one of the things that we've used extensively in desert communities, down in Mexico and South America. And so aloe vera is very therapeutic. Those are great supplements, okay? And they do help, and they do help your receptors, okay? And
Wonderful.
yeah, it's okay. Continue on with those, and also your K2 and the B3s. We're not sure what they do, but they seem to really do help. So anyway,
Yes.
keep those up. Yeah.
Yes.
Mark, I'd like for you to, of course, you know this lady very well. I'd like for you to chime in on anything you'd like to ask her or like to say, and then I'm going to sign off and talking with Michelle and turn everything, the rest of this program over to you to give us an update on. You're doing a lot of more advocacy, and I think it's working because I'm seeing almost each week, I'm hearing from some doctor or nurse practitioner that's realizing how they can at least prescribe opioids and some benzos and start. We seem to be making our headway back a little bit. Yeah. Anyway, go ahead, Mark.
Thank you, Dr. Tennant. Thank you for appearing with us, Michelle. If you look through the archived stories that we have of this recording, you will hear Dr. Tennant talk about other supplements as well, including polypeptides, which can help actually regenerate tissue, particularly in the chronic pain area. And so please feel free to go back and look at all those. But I'm very proud of you, Michelle, about the work that you've done to recapture your well-being and re-engage in life when you were essentially abandoned and left with basically a case of PTSD. So well done.
Thank you. Thank you. Thank you for saving my life.
Well, Dr. Tennant came up with this protocol. I'm just following his lead. Um,
Well, but you're choosing to follow it,
yes.
and you're
Yeah.
choosing.
Yeah, yeah, and he's our hero. I just follow the direction that I'm headed in. I do want to talk about why I haven't been on video during this call, and that is because this afternoon I had 3 patients who lost access to their medications. So it's a scramble every time a stable patient loses their meds, and so I'm not in a good space about the hopeful thing you said recently, Dr. Tennant, because I've been scrambling to help my patients find what they need because they're still, one patient basically goes to the University of Colorado. I think I'd like to play her recording with her pharmacist. She's new to me. Her name is Michelle, and she lives in Denver. And she has been going to the University of Colorado Pharmacy for the last several years. And this pharmacist just decided today to refuse to fill her prescription. She's only been seeing me for a couple of months, and the pharmacist decided he wouldn't fill the prescription. I have obtained a Colorado license. The patient's in Colorado. And listen to, I just want you all to listen to what this pharmacist had to say, and then you tell me what you think.
You know, we're University Hospital. We usually do our providers, so we.
So is it like a monopoly or something, or is it? So you're not open to the public?
What do you mean monopoly?
I mean,
we are, but not typically for something like that. We wouldn't fill for a state provider.
I have a Colorado license. The patient has been using your pharmacy for many years.
You get it from a local provider originally, but yeah, we wouldn't be able to fill that.
So you're not going to fill it.
Local pharmacy.
Okay, well, thanks. Is this in some sort of policy or statute that allows you to? I mean, I don't understand. You filled it before, and you're not filling it now, and nothing's changed.
Right.
Yeah.
Right. We're not going to fill it right now.
You're not going to fill it. Yes, I have a Colorado license.
You get it from a local. Yeah, you could be a local before, but yeah, we're not going to fill it.
So I have a Colorado license. Can you look me up and show that I have a Colorado license?
I'm aware.
We will be visiting.
But we're not filling that. Yeah, but we're not going to be filling that.
Yeah, what do you have?
From a local Walgreens.
So what's your red flag?
For University Hospital.
Yeah, well, yeah, I went to university myself. I graduated from medical school. I understand what a university is, but I don't understand your reason not to fill the prescription.
Okay, I'm done with you.
Thank you. I'm done with you too. Sleep well tonight. Sleep well. Right. Bye-bye. So there you go. That's what we're dealing with. And everyone on this call is dealing with that. I hope you were able to hear the desperation in this fellow's voice. Yeah, Emily, exactly. It sounds like this pharmacist has a gun to his head. He's a university pharmacy and can't fill my prescription. Well, I don't see that as a red flag. So this is what I've been on the phone call about, and why I missed the first half of this call, is these kind of things keep happening. So I'm a little discouraged today, but overall I am encouraged, like you are, Dr. Tennant. I think the tide is turning, but the carnage in the wake of the tide that's turning is what's happening to Monique, this patient, or David, my other patient, that lost access today. So I guess we can pray for these patients. Everybody who's seeing me was desperate before they met me. And then they meet me, and then they're really desperate. I don't know. I'm so consumed by this right now that I can't have anything else in my brain other than my.
But I'm gonna ask you something though. I'm glad you're bringing this to us. It is so You know, I'm like you. What do you say when you see this kind of inhumane treatment? And it's like you know, having been in war and seeing people killed needlessly, and it's the same thing.
Yeah,
This is where one human being is saying, "I want you to die," and let's call it like it is. That's what's happening here.
yeah.
I'm like you. I don't know what to say. Let me see if uh, in these cases, can we come up with something we can at least say to people? Do we say go get some marijuana and kratom? Uh, do we tell them to go down and get some taurine? What do we do? I mean, uh, these people are across the country. They're not here. Nobody wants to listen to them. I'm just we again. For cheap, simple medicines? I again, as you know, we don't get it, but we got to be able to tell people to do something. I guess.
Well, yeah. Number one, get a lawyer. No, number
Yeah.
two, get a witness. Number three, record when you go to the pharmacy and they refuse you. Um, uh, Number four, keep looking for a pharmacy that will fill your prescriptions for you, because getting your legitimate prescriptions on your stable regimen that you're already on is the way to go. During the 2 different weeks that the compounding pharmacy for hydromorphone was offline, you gave me some great tips about helping patients in withdrawal. And so taurine is one of those, and Benadryl and Phenergan and gabapentin. It's the only useful thing for gabapentin is withdrawal. But those things will only treat withdrawal. They won't really approach treating the kind of pain that patients are
Right.
having.
Yeah.
And so, following the protocol, restoring your receptors, and maybe getting some regeneration and anti-inflammatory action going may help to a certain extent, but that's going to be over a period of years that
That's right.
people can come off their opiates, maybe. And, like I remember the naturopath that we had on, who was wheelchair bound, followed the protocol and is now back to work. So those are success stories. And this patient today lost her access and she's freaking out. I mean, and I'm going to do my best to locate someplace for her. But the ironic thing is that Colorado passed a law protecting doctors who prescribe for patients. What that law didn't say, it can't keep people from being held at gunpoint by the DEA or whoever that guy's supervisor is to say, don't fill this prescription for this patient. And it's their patient. This patient of mine has a primary care doctor that's in the University of Colorado University system. So she's in that system. And his logic is completely insane. And I don't know what to do to bring sanity to a conversation that's insane, other than facts, truth, and legal action and litigation, and maybe a picket line outside the pharmacy. I don't know. Other than that, I think it's time for civil disobedience. It's time for civil rights action. It's time for gathering media. It's time for us to stand up, just like we all have been, even though we're so frigging exhausted.
Yes, and we do have some good news that two of our Doc Talks family members have let us know that thanks to some ferocious fighters on our side, one being Dr. Chad Kalas, I probably pronounced his last name wrong.
Hollis. Yeah.
Collis, thank you. But the AMA is actually standing again on our side, saying that we should all be in palliative care and that it is unethical for us not to be in palliative care, that they should not have any interference in the doctor-patient relationship, and also that the telemedicine rules have been extended. That time period has been extended beyond December. So those are some good things. And
Good to know. Do you have a link for that?
I don't at this second, but I will right after the show. I sure will.
Yeah.
Yep. And
Yeah.
Dr. Norm, you have your hand up. So Dr. Norm, please feel free to jump in. We'd love to hear from you.
Yeah. Jamie, I think we're going to run out of time.
Oh, okay. I didn't even realize. Oh, yeah, we are. Sorry.
Yeah, I just want to say I thank you so much and continue to put this out there, and anytime I see where there's some sort of injustice, and I try to put your videos out there, Dr. Forrest, and folks, to let people know, the world know, that there's an injustice that's taking place here. That a pharmacist, I'm a pharmacist, and here I'm sitting in basically unemployed because I reached out to help people and follow the rules, did everything, and had my pharmacy rated, and I'm still fighting. So thank you so much, Doctor.
Thanks, Norm.
Bennett, for the
Thank you.
beautiful
Norman,
work you
keep
do.
those cards and letters coming. Appreciate all you're doing.
Thank you.
One more
Everybody-
thing, Dr. Tennant.
Yeah, sure.
I want to invite everybody on this call to a Zoom call on December 3rd. It's in the middle of the day with myself, Dr. Jeffrey Singer from the Cato Institute, Kate Nicholson, who's an attorney and pain patient, and Ron Chapman, who's an attorney defending doctors. And there's going to be a one hour session open to questions similar to this format on December 3rd. And I'll send that link to you, Jamie, so you can put it in the notes.
Yeah, I'll close. And when we have that session, I think the time has come. Reader's Digest has made the claim that 75% of doctors in the United States now are employed by some health plan or insurance company. And I'm hearing every week that as these plans are telling doctors not to prescribe opioids or benzodiazepines, and I think it's time that these CEOs and these insurance companies and these pharmaceutical chains start hearing from us, because now we've got these powerful finance people out of Wall Street that own these companies are literally allowing somebody like this pharmacist, and I see all of us have got a few names for him. It's just inhumane. So anyway, we'll sign off. Yeah, December 3rd is going to be a great show. Okay. Thanks, everybody.
Thank you, Dr. Tennant.
Thank you,
Not give it up.
That's right.
Don't give up.
See you next week.
Don't give up.
Thank you all so much.
I'll stay on for a
Praying
bit
for all of us. All right.
because I'm mad as hell.
I hear you, and we need some prayers. And so I think we should just pray together before we go. If that's okay with everyone, I'm going to go ahead and we'll just lead a prayer. Heavenly Father, we thank you. Thank you. We know that without troubles, there would be no rescue from troubles. So we know that there has to be something to be rescued from, but thank you for the miracles that have already taken place. Thank you in advance for protecting these physicians, these patients, these pharmacists. Thank you for opening the eyes and ears of people who have not understood until now that they could very easily be in our boat in the blink of an eye. And we thank you for this family that we have. Please give us strength to continue each day and keep binding us together in your love. In Jesus' name, amen.
Everybody else's name too.
Good night.
Thank you.
We love you so much, guys. Good night and thank you. See you next week.